was provided.
This is our final program from the campus of Wake Forest in North Carolina. With its distinguished medical center, the Bowman Gray School, we will look today into the responsibilities of the physician when a terminal illness renders us with the most severe complications. Among our guests will be Dr. Newland, the author of How We Die. Stay tuned.
This program is a Warren Steibel production in association with South Carolina ETV. Funding for Firing Line is made possible by a major grant from the John M. Olin Foundation, Incorporated. Additional support is provided by the Annenberg Foundation, the Laurel Foundation, and the Friends of Firing Line.
In our final program done here at the Bowman Gray Medical Center at Wake Forest University, we examine the responsibilities, legal and moral, of the attending physician. In his engrossing new book, How We Die, Reflections on Life's Final Chapter, Dr. Sherwin Newland recites the circumstances of a suicide by a Nobel Prize-winning doctor. Dr. Newland's sentiments on the point are not to be confused with a moral indifference to suicide or to euthanasia. He sides with Immanuel Kant, quote, "Suicide is not abominable because God forbids it because it is abominable." Yet elsewhere we hear a quiet note of civil disobedience. Like so many of my colleagues, he writes, "I have more than once broken the law to ease a patient's going because my promise, spoken or implied, could not be kept unless I did so." Dr. Newland has been a surgeon and continues as a professor at the Yale Medical School. Dr. Burton Reifler is with the Department of Psychiatry and Behavioral Medicine here at Bowman Gray School of Medicine, a graduate of the University of Washington and of Emory, and a prolific author. Mark Hall is a professor of law and public health here at Wake Forest, familiar to those of you who saw the preceding program, a graduate of Johns Hopkins and of the University of Chicago Law School, and author of several books. So let me begin by asking Professor Hall, are you acquiescent on the point made by Dr. Newland that, in fact, many doctors help their patients to die and to do so?
Basically, I am. I think my position is pretty close to his, which is that physician-assisted suicide is humane, socially required alternative for those who aren't able to take their life in their own hands because of their debilitated condition and who are terminally ill and extreme pain. And that this option ought to be exercised in a very limited and restricted fashion. The interesting question is the extent to which we should legalize, explicitly sanction this alternative. And as Dr. Newland says, it's something that's happened for centuries, as long as medicine has been with us, that it's been quietly done. And so the issue is, do we bring physician-assisted suicide out of the closet, or do we keep it there? And that's a real dilemma. But right now, the legal environment is not as threatening as is sometimes made out. Someone's documented that no physician has ever been convicted for assisting a terminally ill patient to die, although it's happened hundreds and thousands of times. Not hundreds of thousands, but hundreds of times. Although it's technically against the law, it's simply not prosecuted. And it's only taken Dr. Kevorkian to thrust it in the face of the law so insistently that we're forced to respond to it in a more open fashion.
Hasn't been convicted or hasn't been prosecuted?
Convicted.
But has been prosecuted?
Rare instances, but when one hears of prosecution for assisted suicide, it's much more often a family member who smothers or puts a gun to the head, that sort of thing, but very rare with physicians, and rarer still that they're actually punished.
I had a discussion a couple nights ago with a distinguished urologist to whom I spoke about your book, and he said, "Yeah, that's right, that kind of thing happens." And I said, "What is the exposure?" "Well," said he, doctors themselves don't give the anesthetic. They specify to the nurse. how much to give, and of course the nurse can know that it's an inappropriate dose, and could theoretically testify against the doctor or call up the district attorney, in which case it becomes a criminal rather than a civil situation. Is that a workaday experience?
That's a difficult question to answer because doctors obviously don't even speak to each other about it. We know it's done, but it's more a tacit understanding that it's done. You know, until about 10 years ago, one could literally ask a nurse for an overdose of morphine or whatever it may be and walk to a patient's bedside and put it into an intravenous solution and sit by the patient's bed until the eventual ending had occurred. Everybody has become so conscious of suits, most particularly, interestingly, the nurses, so that you can't do that anymore. And you cannot even overdose a patient because the nursing staff tends to be on the qui-vive, as it were, for this kind of thing. So what we're doing is we are, in a sense, phasing out something which, understandably, we've been doing for a long, long time. It's becoming increasingly difficult to carry out this kind of so-called active euthanasia, regardless of whether it's the patient's wish or it's coming into the obvious course of the disease process.
You mean because you feel that the camera's everywhere watching all the motions and ready to trip you up if in fact they see that this is going on?
I think it's clear that that's true. The mere fact
it has to be collusive, doesn't it, really, with the patient and with the nurse?
It has to be collusive with the nurse. It has to be collusive with the family, which is part of the consultative process that perhaps we may speak about later. This is not something done by an individual. I'm sure it has been done by an individual on his own hook, but that is not anything I think an ethical physician would consider an appropriate thing to do. It's more difficult to collude than it was.
Well, Professor Reifler, what do you think about this sort of dawning acceptance of a divide between practice and the law? We're supposed to be a society governed by laws, or are we really talking about something we'd really rather not talk about, like repealing anti-sodomy statutes that date back to the 17th century? Let's just forget that they're there. Is there a little bit of that sort of shields the genteel practice of euthanasia at the request of the patient?
You don't mind a little disagreement on this program?
Not at all.
Do you?
No.
I wanted to, perhaps in the highest traditions of academia, disagree with my colleague, Professor Hall, that I would take a position opposed to physician-assisted suicide.
Yeah, which is a very traditional position, sure.
Well, I think I'd make a distinction between my own personal view on it, which is if I were old and terminally ill with cancer, with no hope of any improvement and an intractable pain, there's a certain appeal to having someone available to help me exit when I'm ready for that. The thing that troubles me, though, is the potential for abuse.
Yeah.
And even in the Netherlands, where people have talked about physician-assisted suicide, I'm not completely convinced that the Netherlands is ready for it.
Not only that, there are old people in the Netherlands who live in fear and dread that night somebody's going to stick a needle in them because they're sort of in the way. There's no question about that.
And we're seeing cases, in fact, in the bi-weekly trade paper of the American Psychiatric Association last month. There were a few cases in the Netherlands that are going to be before the Dutch Supreme Court, that one case of a patient with chronic depression who was assisted in suicide, that certainly, to me, wouldn't seem to meet the test of an illness with no hope of improvement.
Dr. Reifler's absolutely right. The Netherlands is a perfect example of the reality of the slippery slope. The ethicists love to refer to that. If we start down
the routinization, yeah.
If we start down one direction, there's no stopping point. And there are numbers that are documented that as many as 6,000 people a year in the Netherlands are involuntarily euthanized, depending on how you define the term, but that's quite shocking. And I'm very concerned about those abuses as well. The question is how best to protect against them. And I think that the law is capable of setting adequate safeguards. The only issue is how safe we need to be. In other words, how much tolerance for error do we have? And in the arena of the criminal laws, where we officially sanction the death penalty, we have extraordinary protections. And that's the attitude that the law typically takes with something as serious as officially sanctioning a death. And the various proposals that have been attempted on ballot initiatives in mostly the West Coast, Washington State came the closest to enacting active euthanasia, would require full documentation of the patient's voluntariness and the terminal condition and what have you. Whether
can we engage in presumptions? Most people don't get around to considering living will, right? I mean, so is there a point at which society can encourage a presumption that nobody who is suffering and sort of brain dead really wants to continue to be alive? Or is that presumption, does that presumption run into theological problems?
Well, it certainly runs into theological problems, but those theological problems do not affect, I would guess, 90% of people in this day and age. There was a time, clearly, in the 19th century and well into the 20th century where theological considerations were of great significance. They seem to be less and less so, whether that's for the better or the worse.
Where'd you come up with this 90% business?
Made it up out of the clear blue because because it seems
I think much more
reasonable.
than 10% of the American people would wonder whether the will of God was being traduced.
Not wonder whether. I certainly agree with you there. But I don't think that there would be more than 10% of people who actually would be stopped dead in their tracks in the presence of a very sick and suffering relative at whose bedside they had been for a long period of time as things went on and on and on. Yes, I would guess, I'll stick by that number, that 10, at the outside 15, but probably not even that, would want this to continue.
My brother, Judge Buckley, has in his will that he desires to be put out of his misery if he's immobilized mentally, and adds only this codicil that whatever the procedure is must be sanctioned by a priest. Now, in other words, he will not go further than Catholic theology permits. Now, Catholic theology permitted, for instance, in the famous case of Sarah Lee Quinlan, the removal of all the props except feeding. Now, the only way to affect death in some situations is to keep from feeding them. Is that right? Mm-hmm. That is absolutely illegal in every state, isn't it?
No, not true.
It's not?
It's illegal in Missouri, and that was the Cruzan case. But many states allow the withdrawal of feeding tubes. Now, it's interesting to distinguish between feeding tubes and hand feeding. People who still have the swallowing reflex can be hand-fed, and so...
I have a 3-year-old neighbor in the state of Connecticut who was ruled by her doctor at the Grace New Haven Hospital as being absolutely, I'm told brain dead is the wrong word, because if you're brain dead, you're dead, right? But nothing whatsoever happening here. And the doctor says it might live 30, 40 years, because under the laws of the state of Connecticut, you can't withdraw the feeding tubes. Is this a common problem, or is it just Connecticut that's sticky?
I don't think it's a very common problem, and I don't think it's even a common problem in Connecticut, which, of course, is my home state as well, were such a situation to occur, and a patient indeed had been subjected to appropriate testing, which means a few days of flat brain waves plus certain reflex studies that are done that are negative. There is no question that that feeding tube could be removed at the request of the family. If there were any question at all, it would be brought to the bioethics committee of the hospital, who would certainly agree. There's plenty of precedent for that in our state.
There's a rather precise definition of a total brain death, which is death of the brain stem as well as the higher brain functions. People who have death of the brain stem cannot be sustained for periods of time like 30 years.
What happened in New Jersey when Sarah Lee Quinlan went on living for 2 or 3 years, didn't she?
She lived for 10 years, and it's an interesting example of how difficult it is to predict, because there the doctors were saying that even with the respirator support, she would die within a year, whereas when they pulled the respirator, she still lived for 10 years.
Yeah. What about the wife of the man who did or did not kill her? I always forget what the most recent verdict, the high society lady in Newport. She's been going on for 8 or 10 years, hasn't she?
Von Bülow.
Von Bülow, yeah. Now, who opts to keep her alive?
I don't know the facts of that case. I would assume the family has not made the decision to stop whatever needs to be stopped in order for her to die.
But your point is that stopping it would be approved under the laws of most jurisdictions?
Well, it depends on who opts that very question. So if the patient has left very clear instructions, as your brother or your son, did you say? Yes,
brother,
yeah. Then most states, I think every state would allow. The question is when the patient hasn't left clear instructions, and then it comes back to what you asked before: is can we presume or assume? Many states would delegate that decision to the family and say they can substitute their judgment because they know best the values and proclivities of that patient. But other states, and this was the Cruzan decision from Missouri, say that no, we need clear and convincing evidence of that being the patient's wishes, because in fact they are not brain dead. We're ending their life.
Mr. Reifel, let me ask you, what test would satisfy you that liberties weren't being taken? The acquiescence of the family, or would you need to have some retroactive request by the patient himself?
I assume that what we're talking about now is not physician-assisted suicide, but simply withdrawing treatment. The distinction that I'm making in my mind is that I think doctors have been helping patients die as long as there's been a practice of medicine, and I'm in favor of doctors helping patients die within certain guidelines. I think it's perfectly reasonable to not begin a course of treatment. I think it's fine to withdraw a course of treatment that's already been begun if the patient and family agree. I think that if the patient is incapable of making those decisions, what we would like to see is that they've left an advance directive. Unfortunately, one of the weaknesses in our system is that most people don't have advance directives.
Is a presumption admissible at this point?
If the patient has appointed a health care power of attorney, someone to act as their proxy.
Yeah, you just have to pay no attention to it.
Oh, those are tough. Those are really tough.
I'm asking you tough questions.
Yeah, it is a tough question, and you know, people say that academics is where the rubber meets the sky, and I'll try to not do that. I think that if the doctor and the family are in agreement, even if the patient is not capable of participating, then, and I think another test is this something that a doctor would feel comfortable discussing with a colleague and letting a colleague know what he or she had done. I think if it meets that test, I'd feel comfortable with it.
We shouldn't get too hung up on what is legal or what is permissible. What really counts is what will be prosecuted. And the classic example of that, of course, is the case of Timothy Quill, who had a patient who he had known for some long time, who was dying of leukemia, refusing treatment, and very appropriately refusing treatment, and wanted to die, wanted help with dying. He consulted with colleagues. He spent a lot of time talking to this woman, realized she was anything but depressed, that her decision was quite rational, and he gave her a prescription for a large number of sleeping pills, knowing perfectly well that she would take them and die. He then published the case. Because
before she died?
After she died.
Oh. He
published this case in the New England Journal of Medicine deliberately as a moral test for the rest of us, and perhaps as a legal test. What happened was, this was in Rochester. He's a physician at the Genesee Hospital near Rochester, and the courts refused to prosecute him. There was a grand jury, and they did not indict him. That has set a very interesting precedent, and of course, along with the Kevorkian and the Hemlock Society discussions, has led to a great deal of controversy and airing of certain issues that otherwise would perhaps not be listened to by the general public, including the publication of a recent book of his called Death with Dignity.
Well, now, the Kevorkian case gives us a sort of a melodramatic actualization of what it is I take it we all disapprove of. Namely, somebody says, I want to die, and would you make this easy for me? Nobody here believes a doctor ought to oblige a person in such circumstances, or do you?
Well, earlier on, we were using the term collusion.
Yeah.
When Such decisions are made. A doctor, simply because of the way hospitals function, cannot do it on his own. I'm a great reader of thesauruses, and way at the other end of the thesaurus from the word collusion is the word consensus. I think what Quill is asking for, and I think what many of us who believe in the concept of doctor-assisted suicide are asking for, is that there be a consensus among a number of physicians who have consulted on this particular patient problem, a family, perhaps with advanced directives, or if the patient is conscious and sentient, a consensus that makes those who view this from the outside recognize that it's a completely appropriate thing to do. And that's what is being asked for by Quill and others who believe in doctor-assisted suicide, a series of basically almost regulations, more stringent than the Dutch have, that allows us to make rational decisions at the appropriate time.
In terms of the definition you just made, would you say there is today a consensus in favor of abortion?
I think that there is a consensus that in certain circumstances abortion makes sense for certain women. That's the consensus I see. Certainly not a consensus in favor of abortion.
Well, is there a consensus of a kind you describe in respect of death that says a woman should have the right to decide if and when she wants an abortion with exclusive reference to her own criteria?
I do not believe that in this country there is a consensus that a woman by herself can make that decision. That decision involves medical things, it involves familial things, it involves certain kinds of consultation, so that a woman should not be able, most people believe, it's been my observation, should not be able to decide on her own, I want to do this, and have it done.
Well, as a matter of fact, the statistics are very plain spoken. 70% of the American people believe that abortions in the first trimester are okay. But
on demand? On demand.
No, the answer is no, not on demand. In most circumstances, for instance, something like 80% are opposed to abortions as a form of birth control, or to abort little girls because one wants more little boys, that kind of thing. So you want a consensus that's more formidable than anything that's built up on the subject of abortion.
Exactly.
The statistics on euthanasia are interesting. They're similar, but not quite as strong. Phrasing the question in terms of active euthanasia for the terminally ill, one polling organization found that only 63%, I mean, that's a large majority, but it's only 2/3 are in favor of active euthanasia. It's not a uniform consensus. And
another interesting point is that the groups who tend to be less in favor of euthanasia tend to be the groups who are more vulnerable, the elderly, minorities, people who are less affluent. I think one of the places that we really are missing the boat is that we've tended to romanticize the two extremes. We've romanticized high technology, which is often ineffective. In fact, the results on cardiopulmonary resuscitation are so dismal that some geriatricians have made a case for saying anyone admitted to a nursing home should be automatically considered do not resuscitate unless specifically ordered to the contrary rather than the reverse, which is the way we do it. I think the other thing we've romanticized is assisted suicide, at the end of one's life, being able to go out in this, again, romanticized notion. I think the things that we've missed out on are the everyday things in the middle. 85% of people who request suicide withdraw that request when their pain is properly managed. Advanced directives are usually not obtained, and even when obtained, they're not implemented according to the patient's wishes. I think there's enormous...
A lot of people who attempt suicide and don't succeed do not go back and do it again successfully, which directly confirms your point.
Right, and even more remarkable than that, most people who are resuscitated, the few who are asked by their physician, would you want to be resuscitated again, say no.
But even if there's only a minority of people in favor of receiving assisted suicide, I think it's in some cases, that interest is so compelling that it ought to have constitutional status similar to the right to an abortion. And that issue is presently being decided in Michigan, and I would love to see the Supreme Court take that. But the Canadian Supreme Court addressed the issue and voted 5-4 to refuse a constitutional right for assisted suicide, but it was a close split. And I think the argument in favor is that if we have any fundamentally protected interest, what we do with our very own lives, it has got to be at the center of that. And for those who have no other way to commit suicide besides physician help, it has to be a necessity.
The
that were
potential
made
for
illegal-
abuse doesn't scare you sufficiently, and you commented earlier that you thought that a law could be written with sufficient safeguards to protect against abuse, and I just can't imagine such a law.
Well, I'll take issue with something that both of you have said, which is
very briefly.
Well, who does it? The patient's doctor or professional suicide expert? I think if you have both involved, there's safeguard, because the expert is a professional and won't make the mistakes.
Let's go backward for a minute. If there were legalized assisted suicide, there would be far less call for it than we have today. The possibility of having this thing done is much more important than the reality of doing it. When people ask to die when they are very, very sick, almost always it's not dying that they really want. What they're saying is that the medical system has failed us and something's got to change here.
Thank you, Dr. Newland. Thank you, Dr. Reifler. Thank you, Professor Hall, ladies and gentlemen.
This program was a Warren Steibel production in association with South Carolina ETV. Funding for Firing Line was made possible by a major grant from the John M. Olin Foundation, Incorporated. Additional support was provided by the